Hello, everyone. My name is Jennifer Sweeney, and this is my presentation for my evidence-based project. In adolescence, how does providing incentives for smoking cessation compared to not providing incentives or treatment as usual affect smoking habits within 6 months? The Federal Drug Administration states that use of vaping and e-cigarettes rose alarmingly between 2017 and 2018. With 3.6 million kids currently using nicotine. The National Academic of Sciences in Engineering and Medicine states that exposure to nicotine in teens can rewire their brains, causing them to become more dependent on other substances more easily. Toxic substances are released from e-cigarettes, and there are incidents reported of the devices exploding, causing major injuries. It's likely that if smoking does not begin in the teenage years, it probably never will. But beginning smoking in the teen years can lead to a lifetime of nicotine dependence. So, for my proposed intervention and supporting evidence, there are 3 research studies that I have included. Heffler, Liberato, and Thomas conducted a meta-analysis of randomized controlled studies to determine if providing incentives for children and adolescents prevents the initiation of smoking. It has been determined through their research that if it does not begin in adolescence, it likely never will. Evidence providing during the study supported that the intervention did show a smaller percentage of smokers. Another randomized controlled trial was conducted in the Boston Medical Center's adult primary care waiting rooms. The RCT was conducted by Lasser, Quintiliani, and Truong. The purpose of the study was to evaluate a multi-component intervention that involved health promotion and financial incentive. The purpose of the study was to promote smoking cessation along low socioeconomic and minority smokers. At the end of 12 months, 4.8% of the participants in the control group were confirmed to have stopped smoking, and 18.3% of the incentive group had stopped smoking. A qualitative study was conducted to determine the majority of participants believed that HPFI, or Health Promotion Financial Incentive, was more effective than care as usual, and most elaborated that it was and that it was more acceptable than penalties. The theoretical framework that most closely identifies with this project is the theoretical framework of Larrabee, Quality of Nursing Care. It applies to the question, does providing incentives for smoking cessation compared to not providing incentives affect smoking habits within 6 months? The framework is based on the understanding of healthcare quality with incorporation of economic impact. It is understood that smoking cessation and abstinence promotes optimal health and better healthcare quality. Economic impact is an important factor when examining financial incentives, as there is a need for financial support. In addition, it is important to understand the intervention to determine if the benefit over time, as opposed to providing tertiary prevention later in life, is worthwhile to implement into practice. So for the implementation plan, no personal patient identifiers will be identified in the proposal. Only demographics and outcomes of interventions would be recorded and presented with consent from those participating. Recruitment for internal research would be signed consent from those participating in their intervention to release results, and those results would be excluding patient identifiers, date of birth, medical record, or social security number. Payment or financial incentive is already included in the intervention, and there will be no other payment provided for participation. Equal amounts will be dispersed to each individual. The APRN will lead the group to propose a concept presentation, that will gain support for health promotion and financial incentive. The initial meeting will consist of members of the team identifying and planning goals. In the initial meeting, it will be determined what information needs to be included and researched. Internal and external evidence will be reviewed. The timeline will consist of a 3-month period. At the end of the 3-month period, the final will be composed and ready for presentation to policymakers and stakeholders such as insurance companies and healthcare policymakers on the national and state levels. The outcome measures, one of the screening tools used will be the Smoke-Free Families Core Screening Form. It will be used in an outpatient setting to obtain demographic data. Another form that coincides with the previous is the For Smokers Only Smoke-Free Families Core Baseline Assessment. It is a 3-page document that assesses a person's smoking status as well as their knowledge of smoking and complications, in addition to their willingness to quit. Haunting testing will be done to determine accuracy of reporting. This will be done in an outpatient setting as well. Any significant decline of 25% or greater as an end result in smoking will be considered an effective intervention.